Good evening to all delegates present here. So I'm going to present on sewing needle
Just a
microcapsulotomy.
moment. I want to brief the expert panel. Do you know about sewing needle microcapsulotomy? You will see this is a very innovative thing designed by Dr. Rajendra Prasad from India.
So I got introduced to this particular technique a few months back when Dr. Bharti asked me to do this presentation. And this is a whole running video. It is, apart from a debate, it is also for all of you to know what it is. So we all know Argentinian flag sign. For the non-football lovers, it is the appearance of a runoff when you have a blue-white, blue alternating band. Now, I believe for a mature cataract, good rhexis is the rate limiting step. Once you have a bad rhexis, the whole surgery goes haywire. So what normally happens is we use a cystitome, which is a 26 gauge needle, which we make ourselves, and use it through a side port. The problem with this is that we get a linear cut. Now, when a linear cut is there and there is an intralenticular raised IOP of the lens, the rhexis just runs off because the centripetal forces act on the corners of that nick. So small needle aspiration technique is one thing to avoid it, but every time we use a sharp needle with a pointed tip, which has an irregular configuration, then the nick that it makes is like this. It's a triangle, a star, a linear cut, or a quadrilateral. This is the cystitome. Now what Dr. Rajendra Prasad did was he fashioned a cystitome which was round bodied but with a small puncture like a sewing needle. And the rounded pointed tip was so small that it makes a small round opening on the anterior capsule as opposed to a linear cut by any of the other cystitomes. So now what happens is when we puncture the anterior capsule, it is so small that it allows for the intralenticular pressure to be released because the milky cortical fluid comes out. And then after that, the intralenticular pressure is balanced by the centrifugal forces and the centripetal forces. There is no question of that tearing anymore. So what then happens is all we have to do is go in with the Capsulorhexis forceps, a Utrata or a Haldipurkar as the case may be, and fashion a very controlled rhexis of the size that we want. I want to emphasize that since I have learned this technique, I have done 32 cases of mature cataract, and each and every time I have been able to do a really good rhexis. The few points that need to be taken care of is you need trypan blue staining every time. Make a side port. Since the AC is already shallow, I would not recommend making the main port first. Now, after the puncture has been made, we can see the milky cortex coming out. You can wash it so that you know exactly where the puncture is. So in this video, we can see the puncture in the center. Then you can hold it with the rhexis forceps. No further nicks are required to lift the rhexis edge. If you hold that and start tearing, you can complete the rhexis of the size that you want. Now this becomes very, very advantageous when you have an Intumscent cataract because the AC is shallow. The capsule now does not have any tense pressure on it, and especially during maneuvers, like in this case, this was floppy iris. The moment we started putting OVD and washing out the trypan blue, the rhexis, the pupillary dilatation started to fall. Still, since we had a very controlled rhexis, we were able to fashion a rhexis of our choice and size very, very easily. So what I want to emphasize is Zepto-assisted technology is good for institutes where you have a lot of instrumentation, but for all beginning phacosurgeons who don't have that kind of a setup, this is one technique where not much of extra equipment is required. It is conducive to the level of dexterity that you have as a phacosurgeon. All low socioeconomic group people can afford it because you are using a cystitome which is very affordable. If you don't have it, you can use Sinsky, you can use Mohan Rajan chopper. All of these work, and you can complete a rhexis every time. Every time. I have done it myself. There is no rhexis runoff in any case. In this particular case, we were able to record the movement of the cortical fluid towards the cystitome puncture, which is why I want to show you this video. You can actually see how centrifugally the cortex, spokes and the milky fluid move towards where you have punctured it for the pressure to be released. This was a case we did in topical anesthesia, and it's a wonderful, wonderful technique, and I think all of us should adopt it if we are not planning to invest in a Zepto, especially because Zepto, which Dr. Sujay did not say, every disposable probe causes 16,000, I think. There is loss of vacuum, which is a problem, and if the Intumscent Cataract has a shallow AC, it is not so easy to introduce it and set it onto the lens surface. Thank you so much.
But if we are advocating a package of 1 to 1.25 lakh lens package, the patient can seriously invest in a more foolproof 15K disposable set.
No, this is foolproof. This is foolproof. That is my experience.
I have tried this. Once in a while, what happened with me, like in mid-periphery, I got stuck and it started running out. That was just one case.
No, if the capsule is not healthy, like it has fibrosis or it has some other problem, maybe. But if in any surgeon's hand who is doing regularly a good Rexis on a normal cataract, will not have a problem doing this with
Most of
this.
the time.
But he's a high volume cataract surgeon.
All the time.
And does more than 10, 20, 30 cases per day. So now expert opinion by Dr. Amar Hatem.
Again, I'm really happy and impressed by the two presentations. When there is a real problem without definitive solutions, there are always different techniques, different machines trying to solve the problem. Once we got a single perfect machine, we will never make this discussion. 10 years ago, when film to cataract started, flags,
yes,
they insist that the best thing is the Capsulorhexis. With time, we discovered that micro extensions occur even with film to cataract.
Yes.
So test of time is important. Both are not tested against time. But Zepto looks simple, repeatable, but expensive. I don't know why give you here with 16,000 rupiah. In Egypt, we pay for $200,000. 200,000, okay? You mean that, about 160,000, okay? It is more, 200, the double price. Expensive, need machine, need training, but reproducible. If you have you have rich patients, which I don't think neither in Egypt nor India, those rich people are represent a volume one to pay more 100 or 200, but it is good. For this needle, why you don't, there is a side hole near the tip. Why you don't use it to aspirate instead? Why is this hole
that was the sewing needle, just to show you that how the actual Rexis.
This is the sewing needle.
Yeah.
But
Yes, the
this
one
needle
with
doesn't
Maharajan
hold.
chopper.
No, the one with the hole.
Yeah.
The one with the hole, that was a sewing needle to show the configuration of
Not
the sewing.
this type of shop.
No, that
Okay.
was what was used to fashion this particular cystitome with the same kind of configuration.
It looks working well, but actually, all those people who are doing white cataract, it is unexpected. Whatever the technique, sometimes after removing half of the Rexis and decompress, you surprise that when you change your hand, it extends outward. But it is a good idea. It needs to test it against time, and it is cheap. Very cheap. That's
There
key.
is
It
no extra
very cheap.
instrumentation involved.
I think it will not be more than $10 in India. So,
Like he said, we should see the micro extensions. Previously, we were not aware that femtorexis does have some micro extensions.
Yes,
And this may be having that, but with we have the test of time. We have to give it to the test of time. So.